Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove useful in your line of duty. So I'd like to welcome you to part 56 of our pharmacotherapy MCQ series, which measures in urology. The first question reads, Mr. JKL, 74-year-old Hispanic man, presents to a urology clinic for a routine follow-up appointment. He has a past medical history of type 2 diabetes mellitus. He is hypertensive. He has dyslipidemia and a coronary artery disease, stable angina to be specific. He complains to a urologist of symptoms consistent with erectile dysfunction, which we abbreviate as ED, and the urologist considers treating his erectile dysfunction or ED with sildenafil, Viagra. Currently, he takes 5 milligrams of amlodipine once daily, 5 milligrams of glyburide twice a day orally, 20 milligrams of isosorbide dinitrate thrice a day, 40 milligrams of lisinopril once daily, 1,000 milligrams of metformin after breakfast and after dinner, and 50 milligrams of metoprolol tartrate twice a day. And in addition to those, he takes 40 milligrams of pravastatin at bedtime. So my question to you is, with which of the medications listed below, would concomitant administration of sildenafil be contraindicated? Would it be with metformin, amlodipine, isosorbide dinitrate, or metoprolol succinate? I'll give you 10 seconds to choose the correct answer. So isosorbide dinitrate is the correct answer. Now we know that sildenafil is a phosphodiesterase type 5 inhibitor, which is contraindicated in patients on nitrate therapy. Phosphodiesterase 5 inhibitors inhibit the degradation of guanylate cyclase, which is abbreviated as cGMP. Now the result is excess cyclic GMP, which may result in significant hypotension, and thus the use of the two drugs concomitantly or simultaneously is totally contraindicated in pharmacotherapy. Let's move to the next question, please. And it reads, Mr. GSO, a 57-year-old male patient, presents to the urology clinic at your hospital. He suffers from allergic rhinitis, he's hypertensive, and he also has hyperlipidemia. And during this particular appointment, he complains of erectile dysfunction, which he says has been going on for some time now, in his own words, though he has been embarrassed to mention it during his appointments. The clinical pharmacist in your team conducts a thorough medication reconciliation, and she suspects the erectile dysfunction or the ED is related to medication GSO is taking. He currently takes lisinopril, hydrochlorothiazide, pravastatin, fenofibrate, fluticasone nasal spray, montelukast, and aspirin. So my question to you is, which of GSO's medications listed below is more likely to be the cause of his erectile dysfunction, ED? Let's move to the choices. Is it fenofibrate? Is it montelukast? Is it hydrochlorothiazide or pravastatin? I'll give you 10 seconds to choose the correct answer. The correct answer is hydrochlorothiazide. Now, we know that medication-induced erectile dysfunction can occur with several different drug classes, and each of these have varying proposed mechanisms by which the erectile dysfunction ensues or occurs. Now, the common drug classes implicated include those with anticholinergic properties such as the antihistamines, the tricyclic antidepressants, and even antiemetics. And those that alter central concentrations of neurotransmitters such as dopamine and serotonin can also cause erectile dysfunction, and examples of these include the antipsychotics and antidepressants. Now, we also know that vasodilating and blood volume reducing antihypertensives such as beta blockers and thiazide diuretics can also cause erectile dysfunction because there is reduced flow of blood to the penis, which is supposed to be responsible for erection. Now, agents that reduce libido such as estrogens and anti-androgens and even the dopamine antagonists can also cause reduced libido. Then agents reducing response to sexual stimuli such as narcotics and the benzodiazepines can also cause erectile dysfunction. So all those many words justify why hydrochlorothiazide, which reduces blood volume, can cause erectile dysfunction by reducing blood flow to the penis, which is supposed to cause an erection. Let's move to the next slide, please. And the question reads, patient PHP asks your urologist for the best medication for benign prostatic hyperplasia. Now, he has a past medical history of hypertension, coronary artery disease, major depressive disorder. He suffers from an erectile dysfunction, ED, and he also has type 2 diabetes mellitus. They both request you as a clinical pharmacist in the team for an inexpensive medicine which doesn't cause sexual side effects. So my question to you is, which of the medications listed below would be the best choice for Mr. PBH? Would it be tolterodine, finasteride, doxazosin, or sopalmetol? I'll give you 10 seconds to choose the correct answer. So doxazosin would be the correct answer. Now we know that alpha blockers such as alfuzosin, which is marketed as Uroxatro, or silodosin, which is marketed as Rapaflo, or tamsulosin, which is marketed as Flomax, or even terazosin, which is marketed as Hydrin, and even doxazosin, alternative C, which is marketed as Cadura, are all appropriate medications for the treatment of benign prostatic hyperplasia. Now, in terms of cost, terazosin and doxazosin would be the least expensive from that list. Now, alpha reductase inhibitors are more likely to cause sexual dysfunctions because of their ability to lower dihydrotestosterone levels, and they are recommended for patients with substantially enlarged prostates. And the data we are given is not enough, does not give us enough information about the patient's prostate size, and thus we do not know how effective this class of medications might be in the case of this particular patient. And then we also know that saw palmito isn't recommended therapy because of mixed efficacy data in literature out there. So I would settle for doxazocin as the best medication for this particular patient. Let's move to the next question, please. The next question reads, Mr. J.O.K., a 46-year-old male patient, presents to a urology clinic with a chief complaint of, in his own words, feeling tired and depressed. And he adds that he, in his own words, has no desire to have sexual intercourse with his partner. And on probing further, you establish that he finds his female partner attractive, but just doesn't feel like having intercourse with her. On the rare occasions when he tries to have intercourse with her, he can't maintain an erection long enough. And this gentleman is concerned or alarmed and is seeking your help or help from your team. There are no identifiable medications or concurrent medical conditions which may be causing this problem. All the lab results are within normal limits, with the exception of a testosterone level reported as 175 nanograms per deciliter. So my question to you is, which of the regimens listed below would be the most appropriate initial treatment option to address Mr. J.O.K.'s sexual concerns? Would it be alprostadil? Would it be vacuum erection device, which we abbreviate as VED? Or would it be administration of testosterone? Or would you opt for sildenafil? I'll give you 10 seconds to choose the correct answer. So testosterone would be the correct choice in this particular case, and I'll tell you why. Mr. J.O.K.'s symptoms suggest low testosterone levels, which is confirmed with a testosterone level below the 300 nanograms per deciliter mark. His lack of desire to have sex, which is a mark of decreased libido, is a common finding in many patients with low testosterone levels, and this can result in secondary erectile dysfunction. Now, while all the above treatments may be considered in the case of Mr. J.O.K., only testosterone supplementation will address the primary issue pertaining to his sexual dysfunction, which is decreased libido. Now, once his testosterone levels return to normal, if the erectile dysfunction or ED persists, then therapies such as the others listed in the list above can be considered to sort this gentleman out. Let's move to the next slide, please. And the question reads, which of the statements below isn't accurate about avanafil, which is marketed as Stendra? Is it don't use avanafil or Stendra in patients with severe renal impairment? Or is it don't use avanafil or Stendra in patients with severe hepatic impairment? Or avanafil, marketed as Stendra, can be taken with strong CYP3A4 inhibitors? Or avanafil, Stendra, can be taken as early as 15 minutes before sexual activity? I will give you 10 seconds to choose the correct answer. C is the inaccurate statement. Vanafil, which is marketed as Stendra, is an oral phosphodiesterase type 5 inhibitor which is indicated for the treatment of erectile dysfunction, which we abbreviate as ED. Now, the starting dose is usually 100 milligrams taken as early as 15 minutes before sexual activity on a PRN basis, and no more than one daily dose is required. It's taken once a day, PRN, and it can be taken with or without food. Now, we should never use it in patients with severe renal or hepatic impairment. And then I'd just like to emphasize that we should not use it with strong CYP3A4 inhibitors, as its exposure would be increased. Its serum levels would skyrocket to toxic levels. That makes C the correct choice in this particular question. Let's move to the next question, please. The next question reads, Mr. KLH, a middle-aged male patient, presents to a urology clinic for a routine follow-up appointment, and he complains of lightheadedness, dizziness, right knee pain, fatigue and weakness, and occasionally he tells you he experiences heartburn or indigestion. His lab results reveal low testosterone levels. So my question to you is, without his medical history, which of the complaints listed above are more likely attributed to having low testosterone levels? Is it the right knee pain, the lightheadedness and dizziness, the fatigue and weakness, or is it the heartburn stroke indigestion? I'll give you 10 seconds to choose the correct answer. So fatigue and weakness it is. Now, just like to emphasize that low testosterone levels are associated with decreased libido, with decreased infertility, with decreased muscle mass, which results in weakness and fatigue. The testes can be soft. There can be decrease in beard or body hair growth. And if it persists for extended periods, there can be increased risks of osteoporosis. So among all those four choices, C is the correct answer. Let's move to the next question, please. And it reads, your urologist prescribes pseudoephedrine for Mr. T.O.O. So my question to you is, for which of the following set of symptoms would this medication be most effective? Would it be for complaints of frequency, urgency and nocturia, or would it be for complaints of urine leakage with physical activity, or would it be for complaints of hesitancy, weak stream and incomplete voiding, or D, would it be complaints of constipation, abdominal pain and dysuria? I'll give you 10 seconds to choose the correct answer. So B would be the correct answer. Complaints of urine leakage with physical activity. Now we know that pseudoephedrine is a pharmacologic treatment option for the treatment of stress incontinence. I'll underscore stress incontinence. Now the most common symptoms of stress incontinence include urine leakage with physical activity. where physical activity may be, for example, sneezing, coughing, running, jumping, and so on and so forth. So that makes B the correct answer in this particular question. Let's move to the next question, please. And it reads, which of the statements listed below is true concerning avanafin, which is a phosphodiesterase type 5 inhibitor? Is it high fat meals significantly decrease avanafil's serum levels? Is it avanafil has a half-life of 15 hours? Is it avanafil is highly selective for phosphodiesterase type 5 compared to all other phosphodiesterase enzymes? Or is it D, avanafil has been shown to be more efficacious as compared to other phosphodiesterase type 5 inhibitors? I'll give you 10 seconds to choose the correct answer. The correct answer here is C. Avanafil is highly selective for phosphodiesterase type 5 compared to all other PDE enzymes. Now, avanafil, marketed as Stendra, is the latest phosphodiesterase type 5 inhibitor to arrive on the market. And I would like to remind you that it's highly selective for phosphodiesterase type 5, unlike, for example, sildenafil or vardenafil, which also have phosphodiesterase type 6 activity, and even tadalafil, which also has, in addition to type 5, type 11 activity. So in summary, sildenafil, vardenafil, and tadalafil are not as selective as avanafil is, and that makes answer C the correct answer to this particular question. So, my highly esteemed viewers and listeners, that brings us to the end of this brief video, which was the last one under the topic urology. If this video benefited you in any way, I would like to urge you to remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I would like to humbly request you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. Thank you very much for viewing it and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration. I look forward to interacting with you in part 57 of our pharmacotherapy MCQ series. Thank you very much.